Welcome back. So on this lecture, we're going to talk about medication-assisted therapy in two special subpopulations for those in the midst of HIV and hepatitis C treatment. And this is also kind of a review of these two chronic viral illnesses as well. And as you know, as we are in the midst of the coronavirus pandemic, maybe somewhat timely. But you know, opiate use disorder, methamphetamine use disorder, alcohol and benzodiazepine use disorder, all of these are associated with higher rates of transmission and co-infection with these two viruses. So for any provider or healthcare provider, counselor, social worker, working with this population, I think it's good to have some understanding of these two disorders and their treatment, and how they interact with medication-assisted therapy. So we're going to give a quick overview of hepatitis C and HIV, its impact on substance use disorder, and the role of MAT treatment in the treatment of hepatitis C and HIV. So starting with HIV, this is just a quick review, but HIV is a retrovirus. It's based off of RNA, and it replicates by converting into DNA and then inserting itself into the DNA of specific cells in our immune system, primarily T helper cells. It's a member of the lentivirus. It's related to another subset called HIV-2, which is a little rare here in the United States, but also cats and simians can also get a variant of this infection. So there's a feline immunodeficiency virus, and there's simian immunodeficiency virus. SIV probably is the agent, the virus that jumped into humans and evolved essentially into HIV. So what are the risk factors for transmitting HIV? Probably the highest risk is receptive anal intercourse, so being the bottom. Receptive vaginal intercourse without barrier protection, both of these without barrier protection, so not using a condom. These are the highest risk that you have for transmission. For sexual behavior, it's right up there with injection drug use, especially if you don't have access to a needle sharing, needle distribution program, clean needle program, if you're sharing needles, or sharing the wash water or other agents. After that, non-injection illicit drug use, particularly stimulants. So this is snorting or smoking cocaine, having multiple sexual partners, being somebody who works in the sex trade industry, and then also, thank God this is probably more and more rare, but if you're a healthcare worker who had an exposure through a needle stick. On other things to think about too is blood transfusions. So if you do have a blood transfusion outside the United States, it can also be a risk, and you should think about screening. But generally, if you're getting a blood transfusion, like say you're out skiing in France or something like that, or Italy, you break a leg and you have to have surgery, and you have to have a blood transfusion, it's going to be safe in a developed country. So HIV, how does it cause its disease? It destroys part of your immune system. So it kills CD4 T cells. These are important memory cells, particularly for viral, certain opportunistic infections and cancers. So the average time from which someone gets HIV before they have symptoms of it, so that, basically symptoms being they start having opportunistic infections, is 8 to 10 years. So it's a slow course. And that's why it took a long time to identify it in the 1980s as a distinct cause by a virus. But some people have a rapid course. So there are about 10 to 12% of people who progress to AIDS in 3 years. And then we have a small percentage of people we call chronic long-term or non-progressors, and they may have a either a partial or damaged form of the HIV, or they have they've lucked out and there's a good combination of their own innate molecular protections against these retroviruses and the type of particular subtype of HIV they got infected with that allowed them to hold off. You know, essentially they can still spread the virus. They have detectable viral loads, but their immune system never goes to clonal extinction. This is just a cartoon kind of showing you what I just said. That's for the A students who want to look at that. Unfortunately, minorities share a disproportionate burden of HIV and AIDS in the United States. So particularly African-American men who have sex with men, African-American women, and Latino women. And also we're, you know, probably to some degree Southeast Asian and Native Americans have higher use of it. Injection drug users. So I think in general, people who have chronic opiate and methamphetamine problems, in some ways, they're a minority in the sense that they have limited access to healthcare. There's a lot of stigma associated with them. And so they may not get the adequate testing or education or preventative interventions that could help reduce their risk of transmission. People with mental illness, to a degree, have higher rates of HIV as well. So 70 to 80% of AIDS cases in women are in African Americans or Latinos. So this is particularly in women, there is a high, it's very disproportionate, particularly women living in poor inner city neighborhoods. And you know, there's lots of theories of why. I think in general, much to like we're seeing with our current coronavirus outbreak, it's probably not anything inherent physiologically with them, but it's more sociologically. So they have less access to healthcare. There may be institutionalized racism, and that has led to you know, distrust of institutions, public health institutions. And they may be also economically forced into situations where they have sexual relationships that they know other people will be able to avoid in order to maintain, you know, basic shelter and care for their children and things like that. Having both a substance use abuse problem or substance use problem and mental illness, that increases your risk for transmission of HIV. You know, comorbid injection drug use, things like that. So, you know, for substance users, you know, certainly IV drug users have the highest rates for HIV transmission. Stimulants are probably second to that. Alcohol as a whole, maybe less clear association with the alcohol use disorder in itself. But what's been found is like people with HIV who abuse alcohol have problems with adherence and tolerance of their HIV medications. And you know, IV drug users too also have very low adherence to untreated IV drug users have very low adherence rates to antiviral therapy for HIV. Depression has a big impact on HIV. It's been found, and it may be that depression, there's a HIV loves the brain. It causes inflammation in the brain. And so there may be a little bit of the just having the HIV, untreated HIV in itself increases your risk for depression. Or maybe a marker that you have a more advanced disease, because there are studies, especially from the 90s, that indicated that people who had severe depression and HIV oftentimes had higher viral loads, had lower CD4 counts. So it's important to treat depression and other mental illnesses when someone has HIV, not just for the mental illness itself, but it also affects the clinical course of their infection. So So some of the things that you can do to reduce transmission of HIV in the mentally ill, you optimize a treatment plan. You can use motivational enhancement therapy, cognitive MET, CBT. This is a structured-based approach in groups, particularly in group home settings that can help educate and reduce high-risk behaviors in people with mental illness. And then probably the biggest thing is pre-exposure prophylactic therapy. So these are antiviral medications that can drastically reduce the transmission of HIV. So Truvada and Descovy being the ones, and it should be really considered for any high-risk patient. Motivation, well, I've already talked about this in early lectures, so I'm going to kind of skip this, but it's really important. Motivational interviewing is a really important skill set to have if you're going to be treating people with HIV and hepatitis C because of the high rates of comorbidity with substance-related disorders and other issues. And also, motivation is a key factor in adherence to the treatment of HIV. So what are some of the barriers to effective HIV prevention in the United States? It's a lot of the same issues with preventative health that we're seeing now in this pandemic. We tend to over-rely on high-tech solutions, there's the perception that HIV is, because we have had such marked success in treating HIV and really converting what was essentially a death sentence in the 80s and 90s to a chronic illness, that I think, it's not, people are not as scared of it. And that has an effect on reducing and prevention. But you have to realize that, we spend a huge amount of money, and rightfully so, through the Ryan White Act. The federal government pays for the vast majority of all HIV care and assures that anybody with HIV in this country can get treatment for HIV. And then finally, there's a lack of, social empathy and advocacy for those who are at the highest risk of transmission. And, and that's, and that's why I think like HIV is sort of settled into our marginalized and ethnic minorities populations of our country, is because, the richest don't have empathy for them and don't invest as much into trying to bolster prevention. So it's complicated. I'm not going to say I try to find all the answers of it in this particular lecture, but there are a number of barriers to prevention. So how do you treat HIV? It's through something called antiviral therapy, and it's a combination usually of 3 or more medications. I'm not going to go into all the details here. You can hit pause and look at the slide. But essentially it's a combination of 3 or more medications that interfere in different parts of the life cycle of the virus in your during the infection. And these have been a massive game changer. Unfortunately, that doesn't, unlike hepatitis C, where you may see patients who get essentially cured, these medications suppress. And so they can transform, as long as someone takes the medication regularly, and as long as they have a really good infectious disease doctor or primary care doctor who feels comfortable treating HIV, and adjusts the medications based on mutations and resistances, essentially it turns into a chronic illness that then they may have higher rates of other illnesses like heart disease and cancers and things like that. So they'll die of something, but generally they won't die as a result of the HIV, as long as they have access to these medications. Just to give you an idea of the complexity of it, so you have NRTI, you have nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase strand transfer inhibitors, and CCR5 chemokines receptor 5 agonists. So we have a pretty amazing armamentarium, of quiver of treatments. You know, the development of these HIV medicines has transformed molecular biology. You know, we've learned so much about our own genetic functioning and our own immune system through HIV, through the huge amounts of resources that have been invested in researching HIV and in the treatment of HIV. The protease inhibitors was, you know, one of the first, is the first class of medications that was designed from the ground up to affect a particular molecule on something. That was a groundbreaking technological achievement in pharmacology. And it has had a marked impact in mortality. So that arrow right there is where protease inhibitors and the rapid adoption of triple drug therapy happened. And so you see this, you know, kind of scary looking acceleration of deaths and then a marked decrease. But unfortunately, because we really had never, you know, we didn't have the big breakthroughs in prevention. So we never were able to get the rate of infection down to 0. And so the rates of death have, you know, somewhat plateaued. Although we've had, you know, marginal decreases in deaths along the way, but they haven't gone down to 0. There's a lot of side effects with HIV medications being aware of this, helping patients through this so that they can tolerate the medications better is really, really important, because HIV, you know, there's a very thin margin of error. You know, just skipping or taking the medication wrong for a few days out of the month consistently can cause mutations where a person may lose response to entire classes of HIV medication. So it's very, very important to help patients be as adherent as they can once they start HIV treatment. And this is just a table of, you know, that especially the older medications have a lot of neuropsychiatric symptoms. The good news is that the newer generations of medications we've been able to reduce some of these symptoms and make them more tolerable. Probably ephemera is the most, you know, one that's has the most pathognomonic. This is one where people have very vivid dreams and depression. They can have suicidal ideation. But you can also see it in some of the other medications as well. So what are some interventions that you can use to reduce transmission of HIV? I do think, like in the substance use realm and mental health, it's very important that we try and reduce the transmission of this, because once someone has HIV, they have it for the rest of their life, and it's a huge cost to society, but it's also, you know, it's a big impact on the patient as well. So I think you know, you want to treat them on STD risk reduction. Male circumcision can help, especially there's a lot of really good studies out of sub-Saharan Africa that the circumcision can reduce transmission rates. Using PrEP, you know, using these, they're FDA approved, anyone can prescribe them. Some places you don't even have to have a prescription. And really encourage, you know, educating your staff and encouraging your psychiatrists even to prescribe this on your high-risk patients. Post-exposure prophylaxis for if somebody, you know, sometimes this can happen. You can have somebody who knows, like, you know, I messed up on Friday and ended up, you know, having unprotected sex. There is a window where you could use, you know, antiviral therapy, and you might be able to prevent them from having an infection. CBT has been found. There's CBT modules for addressing high-risk sexual behavior and risk factors for HIV as well. So some of the key points with MAT, you know, HIV infection continues at a constant rate, especially with women, ethnic minorities, and mentally ill. Mental health and substance use evaluations should always include HIV risk assessment and screening. And substance use treatment plans should always address reducing high-risk behaviors that might lead to the transmission of HIV. And these are some resources that you can access as well. So hepatitis C. This is something that also we probably see a fair bit more of this in Sacramento County. There's a high rate of this co-occurring with substance use disorder. And really this was found, this is a good example here where they're looking at a residential treatment center and they found like over 20% were positive for Hep C. So there are several landmark screening preventative health studies in institutionalized settings. So looking at inpatient and outpatient psychiatric settings that found extremely high rates of Hep C that they were completely surprised to find. So swimming, kind of smoldering around was this kind of silent epidemic of this chronic, and again, another slow viral infection in which there's really no, up until the past few years, really wasn't a good treatment for, but also much more insidiously with Hep C is that people don't have symptoms for decades. When really up till 10 years ago, the typical time from infection to diagnosis worldwide for hepatitis C was 30 years. It takes a long time for most people to show symptoms, and whether the symptoms, well, liver failure or liver cancer. So it's pretty bad. Like once you start having symptoms, it's like really, really bad. So, and a lot of people have it. 3% of the global population has it. High economic burdens, very big cause for liver transplantation and hepatocellular carcinoma, hundreds of thousands of deaths annually. Again, it has a very complicated life cycle. It's a retrovirus like HIV, but it has a slightly different, uses slightly different mechanisms within our cells for its life cycle. IV has a very high correlation with IV drug use. You really have to have a lot of exposures or a pretty high viral load to get it through sexual activity. So usually it's like sex workers, or if someone is a sex worker and the person has open lesions, yeah, but probably the vast majority of people get it through either injection drug use or blood transfusions or iatrogenically in a healthcare setting with a dirty needle or something like that. You could also, for a long time, it was in the blood supply, unfortunately, because there wasn't a good test for it. There are 6 genotypes of hepatitis C. The more common ones in the United States are genotype 1, 1A, 1B, and 2 and 3. Just for more like medical trivia, if you happen to see somebody who has hepatitis C genotype 4, almost all of those cases come from Egypt because of contaminated blood supply for several years. So the workup for hepatitis C. So again, like HIV, you should think about universal screenings on all your intakes. So if you're treating somebody for methamphetamine use disorder, heroin use disorder, alcohol use disorder, you really should have, you should screen all of those patients as part of the intake for HIV and hepatitis B and C. So once you have a positive antibody, you need to see, did they have actual disease? Because there's a difference between having the antibody and having active disease. So with hepatitis C, about 25 to 30% of people infected will clear the illness on their own. But that leaves 75% of people who go on to have a chronic illness from it. Hepatitis B is somewhat the reverse. So 75 to 80% of people clear it. They may have a short infection rate, but only a small percentage go on to have chronic disease from hepatitis B. So with hepatitis C, once you have a positive antibody test, you need to do a viral load. The viral load shows that there's a high titer of it. You need to do a genotype, and then you need to assess their liver function with some blood tests. You should also think about, especially if they're going to get treatment, you should get a liver biopsy. There are some blood tests and non-invasive ways to assess how severe their liver disease is. But the gold standard is a liver biopsy. If they have cirrhosis and they have a high alpha fetoprotein, then you really got to work them up for hepatocellular carcinoma. So you really have to have an experienced internist or family medicine doctor who can work with a hepatologist who has a Hep C treatment program. The good news is we have plenty of that. We have very high experience with hepatitis C here in Sacramento. There's lots of gastroenterologists, hepatologists, and also just general internists who can treat this disorder. The treatment for Hep C has evolved significantly since I've been in residency. We had like pegylated interferon or ribavirin. It's very toxic. You had to inject yourself. You had to be on it for between 3 and 12 months, sometimes longer. Now the standard of it is similar to HIV, is a combination of antiviral medications. These are very expensive. Probably the ones you may have heard about are Harvoni. But there are other combinations that are listed down here. And these are the directly acting antiviral therapies for hepatitis C. And these have been a game changer, particularly for genotype 1, which with the old treatment paradigm, had a 50% cure rate. Now, if a person is able to tolerate and are adherent with a few weeks on these newer medications and combination medications, they can get a cure for hepatitis C. And luckily, I've had a number of my patients get through this treatment. If they're very expensive, you're talking thousands, tens of thousands of dollars a month. But like I've had these discussions with insurance plans, it's far, 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 far cheaper than a liver transplant and the expense that goes into maintaining the liver transplant or hepatocellular carcinoma. So it's very expensive up front, but then especially in my experience, sometimes people being diagnosed with hepatitis C is the straw that broke the camel's back that finally gets them motivated for treatment, and a lot of times they really have changed their lives at that point. So in summary, there's been a great expansion in effective treatments for hepatitis C. Antiviral medications targeting the replication cycle of hepatitis C have greatly improved treatment outcomes for the most common genotypes. These treatments are very expensive but have high cure rates if correctly administered. Opiate users with comorbid hepatitis C, unfortunately, are less likely to get access to the treatment of liver disease. So that's a population we should try and do our best to stabilize them and get them into treatment. Comorbid substance use disorder, especially IV drug use, is very, with Hep C is highly prevalent. And so you really want to coordinate MAT treatment, substance use counseling with an adequate evaluation to give them a chance for treatment. I think ultimately MAT can be a lifesaver in this patient population because if you're actively using heroin or methamphetamine, there's just no way you're going to get be compliant with all the lab work and diagnostic testing and appointments that you're going to need for a few months to get a cure. So the first step is to get them stable enough and functional enough so that they can do that. And that's what the goal of, in my mind, of what MAT treatment is with hepatitis C. And no audience, but hopefully you'll send some questions to Deborah. And I will end it here.